With anatomy out of the way, let's move on to renal physiology. This is where the bulk of the material will be for renal. Since the kidneys are the primary regulators of body fluid volume, let's start with a discussion of fluid compartments. You probably remember that the body's total water is split into several compartments. Before we get into the differences between them, let's just walk through a sample problem. Ready? How is the body water of a 70-kilogram man divided? Let's go through it together. If he weighs 70 kilograms, then 60% of that will be water. This is about 42 liters. Then, of that, 2/3 is intracellular, or about 28 liters. The remaining 1/3, about 14 liters, is extracellular. Of the extracellular fluid, about 1/4, or 3.5 liters, is in the plasma, and the remaining 10.5 is in the interstitial space. Now that we have our example calculation, let's talk about the differences between these compartments. The extracellular fluid, or ECF, has a very different composition than the intracellular fluid, or ICF. The major cation in the intracellular fluid is potassium, while in the extracellular fluid it is mainly sodium. They also have different anions. Inside the cells it is mostly protein and organic phosphates, while outside the cells it is mostly chloride and bicarbonate. However, the osmolarity of both components is about the same, at 290 milliosmoles per liter, which means there is no net movement of water in or out of cells at rest. One important thing to remember is that the calculations we just did only give you estimates of fluid volume. In order to measure plasma volume directly, you can infuse radiolabeled albumin, since albumin remains only in plasma. Similarly, in order to measure the ECF directly, you can infuse inulin, since it will remain only in the extracellular fluid without going into cells. Now, in real medical practice, no one would ever do these things. They're slow and expensive, and the simple calculations we did are good enough for most purposes. But on the exam, you might need to know how to use these tests. So let's see how that would work with a sample question. Ready? You infuse 1 gram of radiolabeled albumin into a healthy 70-kilogram volunteer. After equilibrium has been reached, the plasma concentration of radiolabeled albumin is 25 milligrams per deciliter. What is the volunteer's plasma volume? In order to answer this question, we just need some simple math. We infused 1 gram, or 1,000 milligrams, of radiolabeled albumin. If the concentration ends up being 25 milligrams per deciliter, and we started with 1,000 milligrams, then there must be 1,000 over 25 deciliters of plasma. 1,000 divided by 25 is 40, and 40 deciliters is equal to 4 liters. As you can see, this measured volume of 4 liters is roughly equal to the calculated volume of 3.5 liters that we had from before. Now let's move on to the actual function of the kidney, starting with filtration. The glomerulus is a very delicate structure that acts as a filter for plasma. Using an endothelial size barrier, a basement membrane charge barrier, and a podocyte barrier, the kidney makes a tight meshwork to prevent things from leaking out of the vasculature. This is especially important to keep protein, which tends to be large and negatively charged, inside the blood. If this barrier is lost for some reason, the kidney will leak protein, leading to decreased oncotic pressure and edema, as in the case of nephrotic syndrome. In a normal kidney, only small solutes are freely filtered through the glomerulus. Now let's move on to some equations that are important for renal physiology. The math isn't too complicated, but you should still be comfortable doing these calculations. Let's start with renal clearance, a concept that is especially important for pharmacology. Clearance basically describes how much plasma is cleared of a certain substance X over time. One important thing to remember about clearance is how it compares to GFR, which we'll talk about in a minute, and how that relates to the net absorption or secretion of a particular substance. First, let's talk about GFR, or glomerular filtration rate. Conceptually, this is how fast fluid is filtered through the kidney, but practically, GFR is used as a proxy to measure kidney function. GFR also represents the balance between the stalling forces in the glomerular capillary. Hydrostatic pressure trying to push fluid out, and oncotic pressure trying to keep fluid in. You should also remember that inulin clearance is the perfect method for measuring GFR, but clinically, almost everyone uses creatinine clearance because it is easier to measure, even though it might be a slight overestimate. Now let's move on to renal plasma flow. Conceptually, this refers to the amount of plasma flowing through the kidneys over time, but it can't be measured directly. Instead, we use effective renal plasma flow to estimate it, even though it's an underestimate by about 10%. Once we have renal plasma flow, we can use that to calculate the full renal blood flow using the formula that adjusts for hematocrit. This next fact defines filtration fraction, which is the fraction of plasma going through the kidney that gets filtered, and is calculated by dividing GFR by RPF. It's normally about 20%, but it can be altered, either with natural hormones or with drugs. For example, angiotensin II preferentially constricts the efferent arteriole, which leads to a decrease in renal plasma flow, but that also tends to increase GFR by increasing the hydrostatic pressure gradient, so the filtration fraction increases to more than 20%. This and other changes in arteriolar dynamics are laid out in the following table. To understand this table, you need to understand how RPF and GFR will individually respond to each of these. Since renal plasma flow is just a measure of blood flow, anything causing arteriolar constriction will lead to a decrease, whereas nothing else will affect it. On the other hand, to understand the changes in GFR, it's important to think about the stalling forces that we talked about. Efferent arteriolar constriction, like we talked about with angiotensin II, causes an increased hydrostatic pressure gradient, which leads to an increase in GFR. On the other hand, afferent arteriolar constriction leads to a decrease in the same gradient, causing GFR to go down. The same hydrostatic pressure gradient is also decreased by constriction of the ureter, which decreases GFR. The changes with plasma protein relate to the oncotic pressure gradients. Let's think about this in the context of some sample questions. Ready? Question 1. In a patient suffering from protein malnutrition, would you expect GFR to be higher or lower than normal? If you said higher than normal, you're right. Someone suffering from protein malnutrition would have low serum albumin, since she would not be able to make enough protein. With that lower plasma protein concentration, the oncotic pressure keeping fluid in her plasma would be less, so GFR would be higher. On to question 2. How will the filtration fraction of a patient in the early stages of shock compare to a normal filtration fraction? This is a tough one. When people are in shock, they aren't getting enough blood to their vital organs. In the kidney, that means that renal plasma flow will be low. The body responds by selectively vasodilating the afferent arteriole while vasoconstricting the efferent arteriole. This has the effect of increasing the net hydrostatic pressure gradient, which in turn raises GFR. Since renal plasma flow is decreased but GFR is increased, the filtration fraction will be higher than normal in a patient with shock. Great. Now let's finish up these calculation-heavy topics with a brief mention of reabsorption and secretion rate. Using the equations listed here, you can calculate how much of a substance gets filtered through the kidney and how much gets excreted. If there is more being excreted than filtered, then somewhere along the kidney there must have been net secretion. On the other hand, if more of it is being filtered than excreted, somewhere along the nephron there must have been net absorption. With those concepts under our belt, let's move on to two specific substances where it's really important to know how the kidneys are handling them. The first is glucose. Normally, glucose is freely filtered through the glomerulus, but is completely reabsorbed in the proximal tubule through co-transport with sodium. That makes sense, since glucose is very important to the body, and peeing all of it out wouldn't be a good way to live. However, if the plasma concentration of glucose gets high enough, there's too much for the proximal tubule cells to handle, so some of the glucose comes out in the urine, or glucosuria, and the problem gets worse the higher the value of glucose in the plasma. This is the key problem with diabetes mellitus, where glucose spills into the urine due to very elevated plasma levels. The second important substance to understand is amino acids. Normally, these are small enough to be filtered through the glomerulus, but then they are completely reabsorbed by co-transport with sodium. There really shouldn't ever be amino acids detected in the urine, and if there are, it's a sign that there might be some genetic deficiency in amino acid reabsorption. For example, in Hartnupp's disease, there are no transporters for tryptophan, and since tryptophan is a precursor for niacin, this results in pellagra.